So good afternoon, everyone. We're about to get started. My name is Katie Dane. I'm the CEO of the NCD Alliance, and it's a real pleasure to be moderating this session entitled Promoting Child Health and Wellbeing to Prevent and Manage Non-Communicable Diseases, Investing in a Healthier Future, which is co-hosted by UNICEF, Novo Nordisk, and the NCD Alliance. In the next 90 minutes, we're going to dig into the evidence and the case for why NCDs are a public health challenge for children and adolescents, and explore the solutions, what's working, real-world examples, and what role different sectors have to play. We've got a fantastic lineup of speakers for you. Before I introduce our first speaker, allow me to share a few kind of framing remarks, which really set the scene for this discussion. This session is obviously happening just a few weeks after the fourth UN high-level meeting on NCDs and mental health, which happened at the UN in New York. It was 7 years since the last high-level meeting, which took place in 2017. Many governments showed up at the highest level, made statements on NCDs, negotiated a new political declaration, and made new commitments and a roadmap for action. The overall backdrop of this high-level meeting, I would say, having been involved in all four over the last 15 years, quite challenging to say the least, for two reasons really. Number one being that overall, in terms of the NCD response, we are off track significantly in terms of achieving SDG target 3.4. Just 19 countries out of 194 are currently on track to achieve that target. And in over 60% of countries, we've actually seen a slowdown in the rate of decline in premature mortality in this decade compared to the last. So in many ways, we're actually going backwards. In terms of what was agreed, the political declaration, which was put forward for consideration, not as strong as we would have liked, perhaps. Normally, it's approved at these high-level meetings. It was put forward. And that's really a reflection of, obviously, the fragmented world that we are living in, the challenging geopolitics around these negotiations in New York. But we're very hopeful that this declaration will come back to the UN in a couple of weeks' time for adoption by the vast majority of governments. In terms of the content of what this new declaration really outlines, I think I'll just highlight a few things particularly relevant for this conversation today. Number one, mental health is included for the first time in a really meaningful way. Mental health was recognized back in 2017 as the fifth disease and condition that is part of the NCD agenda. But this time round, it was really included as a public health issue in its own right, as well as very much interconnected to many of the other NCDs. Secondly, the declaration also includes a number of targets. And again, we've been really trying to ensure targets are included in these declarations previously with limited success. So the fact that this declaration has a set of targets, it introduces a new accountability framework for non-communicable diseases across many areas like primary healthcare, prevention, financing, data and surveillance, etc. It also has a really, really strong focus on primary health care and integrated health systems, which I think is really, really important and a real theme of this World Health Summit this week as well. And for the issue of children and NCDs, I think it could be quite a turning point for the agenda, because I think we saw a real reframing of the NCD policy agenda from being primarily focused on older people, an aging demographic, which is obviously critical for NCDs, but also at the same time putting a spotlight on children and young people, particularly in the world's poorest countries. And the declaration recognizes the catastrophic childhood NCDs like type 1 diabetes, sickle cell disease, childhood cancers which can't be prevented. It recognizes the unique mental health challenges of children and adolescents today, the changing face of nutrition in children and young people, which we'll be hearing from UNICEF in a second, as well as the really unique challenges of reducing exposure to the risk factors for children and young people, as well as, of course, calling for public health and health system responses to take a whole life course approach with a particular child-centric effort. Now, as we all know, high-level meetings don't change the NCD response overnight. It's what happens next. But it does really send an important signal and a political intent and commitment by governments on NCDs. It repositions NCDs at the political level after quite a long time, 7 years, as I mentioned. It signals collective action and a multilateral approach, not easy in this day and age at the moment. And it gives those targets that I already mentioned. So hopefully that gives a bit of a flavor of kind of the global policy agenda as it is today, and as what came out of New York and the high-level meeting. And with that, I'd like to introduce our first speaker. We have a keynote speaker followed by a panel. And pleased to introduce Mauro Brero, who is the Senior Nutrition Advisor at UNICEF, who will be giving us a bit more of the evidence and the rationale for why we must put children at the center of obesity as well as NCDs. Over to you, Mauro.
Yeah, thank you very much, Katie, and good afternoon, everyone. Ladies and gentlemen, distinguished guests, it is really a pleasure to be with you today in this very important meeting as we think about how to best invest in the future of our children. And I would like to really thank the NCD Alliance and Novo Nordisk for hosting this event with UNICEF and for the great partnership that we have in addressing the child and health nutrition challenges of children. I would like to start introducing this panel by providing an overview of why we must put children at the center of the global response to obesity and NCDs. So first of all, I would like to start with some good news. If we look in the past 25 years, we have done significant progress in improving the nutrition and health of young children. We were able to reduce by 1/3 the prevalence of stunting since the year 2000. And this was one of the key contributing factors of reducing by half the mortality among children under 5. So this is important progress that should be celebrated and shows that when we know what to do and when we invest in key intervention, we can make a difference. So today we have the largest cohort of children who survived in history. But this is not without challenges. There are new challenges that are affecting our children. UNICEF published a child nutrition report in September that shows a very concerning fact that for the first time in our history, the prevalence of obesity among young children, school-age children and adolescents have overtaken underweight. So today, there are more children with obesity than with underweight. This is a historic change. It never happened in our humanity before. And if we look at the trends, since the year 2000, there are 100 million children more with obesity. And the rate has tripled in the past 25 years. And one myth that we also have to address is that obesity is one challenge of the high-income countries. Actually, 80% of children with obesity live in low- and middle-income countries. And the rate of obesity has increased 5 times in regions like South Asia. So it's a big challenge that we all face as an international community. If we look at other NCDs and the broader map of NCDs, UNICEF shows that 2.1 billion children and adolescents are affected by NCD or exposed to risk factors. It's over 80% of children worldwide. And 1 in 7 children live with a mental health condition. This, again, is happening in high-income countries as well as in low- and middle-income countries. And actually, the challenge in low- and middle-income countries is higher because the lack of access to life-saving care. And unfortunately, tragically, today, 1 million children and adolescents die every year of treatable NCDs, which is 16% of all deaths globally. And 80% of this happens in low- and middle-income countries. If we look at the drivers of obesity and NCD, and we focus actually on the modifiable risk factors, we see a number of issues that can be addressed and that we must prevent. Unhealthy diets is one of the main drivers epidemiologically of the crisis in obesity and NCDs. Inactivity, tobacco use, harmful alcohol use, and air pollution also complement the picture. If we look at unhealthy diets, the problem is that today, increasingly, ultra-processed foods are becoming like staple foods for children. The amount of caloric intake that comes from ultra-processed foods is increasing. And the statistics shows that adolescents globally, they consume daily 1 sugar sweetened beverage and sugary packaged food. So there is a crisis in children diet and other risk factors, but another myth that we need to address is that this does not depend, it's not children or families who are failing. It is actually the systems who are failing children. If you take the food system today, it is failing to provide the nutritious, safe, affordable, and sustainable foods the children need to survive and thrive, especially to the most vulnerable children. But then it is flooding all food environments everywhere with unhealthy, nutrient-poor, ultra-processed food. Health systems are struggling to provide universal access to NCD and mental health prevention and care. Education systems are not yet providing healthy, safe environments, supporting adequate physical activity in the schools. The social protection system is failing to provide the vulnerable families with the social benefit they need to access services and healthy foods. Water and sanitation systems are also failing in schools, in community, and in health facilities to provide drinkable water and sanitation. And also urban environments are increasingly polluted and they discourage physical activity. It is a serious situation that can be addressed especially through policies. If we look and zoom in the food system, we see that one of the main issues of why food environments are not promoting healthy diets, but are flooding the spaces where children live, learn, and play with unhealthy food, is because there is lack of mandatory, comprehensive set of legal policies that incentivize the nutritious and safe food and disincentivize the unhealthy food. And sometimes, one of the main barriers is the interference from the ultra-processed food industry that has been reported as some of the main causes of why these policies are not advancing. This is an example as we're speaking about multi-sectoral approaches. The food system is one key system that we need to address. But it is not the only one. In this slide, it is shown how, in order to have success in preventing and managing NCDs, we need to work across all the systems that I have mentioned. And today, it exists consensus and guidelines at the global level among different agencies, including WHO, including the World Bank, UNICEF, and other key actors about a system-centered approach with children in the center. If we look at interventions that have proven effective, looking first at the food system, we can see that addressing policies to improve food environments is something that can really help to change diets by reducing the offer, the marketing, of the unhealthy foods. But there is no magic bullet. I'm showing here an example from Mexico because it is one of the few countries globally, together with few other examples like Brazil, Chile, and few others, that is implementing a comprehensive set of policies, including warning labels, front of pack warning labels, including marketing restriction, taxes on unhealthy food, incentives on healthy foods, and this led also to formulation and to incentivizing healthier foods, and also marketing regulation. So it is important to adopt this kind of approaches that include a multi-sectoral set of comprehensive policies. If we look at the health system, it is important also that the health system addresses the specific needs of children, and especially it is important to improve how the health system is able to prevent NCD factors and also to manage especially the severe childhood onset NCDs that cannot be prevented but can be managed. And it is important when we work in the health system to look at a holistic approach, looking at the enabling environment, the policies, the financing, the data, but also the capacities, both at the community level, at the health facility level, at every entry point, and making sure also that we work to strengthening both the supply and the demand side. Another very important approach that is being increasingly undertaken today is the approach of One Health, which acknowledge that the health of people and the planet is interconnected. And it is very important in terms of policy coherence, because when we implement the policies that improve urban spaces, it both reduces pollution by reducing the number of vehicles circulating and improves physical activity. Or when we address and limit the production and the consumption of ultra-processed food, we limit also the impact on the environment through the processing, the packaging, the transport, the freezing, etc. So the One Health approach is also very important to combine addressing planetary health, human health, and the food system. And to conclude, I think it is necessary for us to take this very seriously and to act together. And it is important when we speak about the whole of society approach that we make sure that the governments are at the center. The governments are those responsible to enact and enforce the policies and to provide the services that we need to prevent and manage obesity and NCDs. But they cannot do it alone, and every single actor in the society has a key role to play, from the academia to the civil society, to the people living with these experiences, to children and youth, to development agency, and of course to the private sector, who can and need to be a force of good for children. So this is just to introduce the panel discussion, and I thank you very much for your attention and looking forward for more discussion.
Take a seat. Thank you, Maru, for setting that big picture view and the evidence around children and NCDs. Let me now bring on our fellow panelists to the stage. So very pleased to be joined by Jeremy Farrer, Assistant Director General for Health Promotion, Disease Prevention and Care at the World Health Organization. Welcome, Jeremy. We also have Javier Calatrava Sanchez, Coordinator of Health Promotion and Prevention at the Madrid City Council. Please come up as I introduce you. We also have Emanuela Selassie Homeno, a youth advocate representing the civil society organization Youth Diabetes Care in Ghana. Welcome, Emanuela. And finally, Joe Jewell, who is the Director of Social Responsibility at Novo Nordisk. So welcome, everybody. So, as you can see, we've got an excellent multi-sectoral panel where we have multilateral agencies represented, we have city-level leaders represented, civil society, and of course, the private sector. So in the panel discussion, we're going to focus on two different aspects. The first round will be focused a little bit more on general reflections and perspectives on child health and NCDs. Why is this important? And what different organizations and entities are doing to respond. And then we'll have another round where we get a little bit more into the detail of some of the concrete solutions. What's working? What are the barriers and opportunities? And some practical lessons learned, some insights. Because as I mentioned at the beginning, you know, one of the kind of moments that we're at in terms of the NCD response is that, in a way, there's been a policy success, but an implementation failure. And we want to make sure that over the next decade, we're really tackling that implementation failure and moving into more sustained action. So, Maru, let me come back to you to start with. So you'd obviously kind of presented in your keynote UNICEF's approach, obviously working across sectors with government, with civil society, with the private sector to scale child-focused efforts on NCDs. Can you share a little bit more about what that approach looks like, particularly in terms of responding to obesity and NCDs?
Sure. So in UNICEF, I think we have multi-sectoriality in our DNA, because our agenda really is to address children's rights, so every right of every child. And we have different sections in our organization. We have a health and nutrition, water and sanitation, social protection, education, social policies, among others. So for us, it is very important to have a holistic approach to the work that we do. Our priority is always the prevention, but then when the prevention fails, also the care and the management and the treatment is a must, because it is also about the rights of children to survival and to thrive. And our approach is a multi-systems one. We work to generate evidence, because this is very important for decision-making, both in terms of strengthening policies and improving the coverage and the quality of services. And then we use this evidence to share it with our main counterparts, that it is the governments. And so to support, provide technical support and guidance to governments to improve policies and services. There is also a very important component that it is about advocacy, because sometimes the agenda is not always easy, especially when it is an agenda that needs to regulate something. Regulations are never sexy, even if they are necessary. And I think one of the key elements in this advocacy is the role of UN in general as non-partisan agency that can work really based on evidence, but also the involvement of youth. We work a lot with youth to help them strengthening their capacity to advocate for their rights, and including youth who live with certain conditions, that can be obesity, that can be NCDs, and so they know exactly what are the gaps and what are the needs. And we work across different platforms. The health system is a very important and the primary one to strengthen the prevention and the care, but also schools are a very important platform because they capture all children, of course, and then it is important to opportunity to strengthen their capacity, provide some key services. And finally, also the social behavior change for us is a very important component. It is a communication that really addresses the barriers and also the enablers of a behavior that can be changed, working more on the emotions maybe than the knowledge, and also we aim at creating a state of opinion in the society so that the youth and the society in general can also claim for these policies and services.
Fantastic, thank you. So really multifaceted. And I have to say that having worked in the NCD space for a little while now, I remember back in 2011 with the first high-level meeting, it was very much kind of WHO at the helm as the kind of leading technical agency for health, and very few other UN agencies really kind of putting NCDs as kind of a priority. So having UNICEF around the table now as such a leader is absolutely valuable. Jeremy, let me bring you in here, and thank you for joining us. Question to you, and we kind of touched upon it earlier in the plenary briefly. Obviously, progress on childhood health, NCDs, and mental health depends a lot on political will. Essentially, having governments really putting and prioritizing these issues at the highest level. From your experience as ADG, what really motivates governments to put NCDs up there and to keep it up there, given that this is a kind of long-term chronic issue?
So I think many things, and I do agree with you that whilst I think political will is a critical component, I don't think we can assume that political will on its own is enough. Because, sorry to say it, but even mayors, but certainly ministers come and go, governments come and go, priorities change. We've seen that when terrible issues at the moment, like Ukraine and other things, they can fast track a government and take it rightly off gender. So when there are political moments, like in the General Assembly this year around NCDs and mental health, it is crucial to grab hold of those. But then not to assume that when you leave New York, it'll all happen. And that's where, and I've said this many times, and apologies for saying it again, that's where the responsibility of not just saying that lot over there in government will do it, but then owning that responsibility, our collective selves, to make it happen. The second thing I would say is that I think we underestimate how much governments actually respond to their citizens. Not every government, not all the time, but creating a movement within citizens and within societies is absolutely critical. And this conversation is around childhood health and well-being, and we have a lot of discussions, rightly so, about youth engagement. I just don't underestimate the power of grandparents and parents. They tend to vote more than adolescents and young adults do, and they have a tremendous influence on the way governments function. And then lastly, political will doesn't stop at national governments. Many countries are federal, and I think whether it's this issue or climate change or urbanization, I think mayors have an absolutely critical role. and the role they play in driving change, but also being capable of experimenting. So countries are not monolithic in how they respond, but cities can experiment and regions can experiment, and then other regions within the same country can adapt. So political will is critical, political action is critical, but don't assume that that will lead to all the change that's required. Carry the responsibility ourselves rather than just pretending somebody else will do it.
Great. That's a very nice segue to Javier, who, as I mentioned earlier, is the coordinator of health prevention and promotion in the Madrid City Council. So we're going from multilateral global down to a municipal city level. And as Jeremy was just saying, city leadership is critical for issues around childhood health and NCDs, particularly in terms of shaping the environments that people, children are living in, as UNICEF was presenting earlier. How has Madrid approached this through a kind of city-wide strategy, and what impact are you seeing with children and families?
Well, thank you, Katie. For me, it's an honor to be here. Madrid has taken a strong and coordinated approach to child health through a citywide strategy led by Madrid Salud. Madrid Salud is a public entity under the City Council. At the heart of this strategy is the Subdirectorate for Prevention and Health Promotion. This strategy is formally committed to the National Health Promotion and Prevention Strategy. Madrid Salud, we coordinate a network of 16 municipal health centers covering all 21 districts of the city. And this team works with interdisciplinary and community-based approach guided by the principle of proportionate universalism. That means we focus on equity and in social determinants of health, especially in vulnerable areas. To identify these priority zones, we use indicators like income, education level, or mortality, and every 4 years we conduct a comprehensive health study of the city. This helps us to design programs that address key risk factors such as poor diet or lack of physical activity, recognized by the UN General Assembly Declaration as a major contributor to poverty and inequalities. And our recent data shows that children obesity is a serious concern. Up to 45% in some districts of children ages 3 to 12 are overweight or obesity. These areas also face higher vulnerability, especially among single-parent family. We see that mental health risk is higher among children experiencing food insecurity. To respond, we have developed a structured program focuses on this life stage. One of our flagship projects is Coles con Alas, which stands for Schools with Wings. Between 2021 to 2024, it reached 9,000 children and reduced by 2% the excess of weight and improved by 3 points adherence to Mediterranean diet while achieving a strong family satisfaction. To further expand and intensify this project over the coming years, we have joined forces with the Childhood Obesity Prevention Initiative, an international program led by Novo Nordisk, where Madrid Salud will be participating with together 5 cities. To promote physical activity, since 2013, we have worked with the Urban East Department to create more than 120 kilometers of healthy walking routes across the city. These routes are available to everyone, including schools and children. They encourage physical activity and social connections in the communities. This initiative was recognized by our Spanish Agency for Food Safety Administration in 2024. All of this shows that when health is integrated into education, urban planning, or social services, we can make a real impact. I think Madrid's strategy is a living example of how cities can improve outcomes for children and families through coordinated, community-based action.
Fantastic, thank you. Really concrete examples, and I think, we saw at the high-level meeting as well that the Spanish government just really kind of leading on NCDs at the moment. So it clearly comes from very much, the highest political level all the way down to the city level. So congratulations on that experience. Let's come to communities. So we've talked about, global multilaterals. We've talked about the city level, Emanuela. Now let's bring in the kind of civil society and lived experience in youth. You're obviously a youth advocate representing the civil society organisation Youth Diabetes Care in Ghana. And you've turned your own lived experience into a very powerful platform for advocacy. We'd love to hear a little bit more about what motivated you to start advocating for youth with diabetes and what change you're working towards at the moment in Ghana and beyond.
Thank you, first of all, for that question. What motivated me to begin advocacy, first of all, was my experience as a person living with diabetes within the healthcare system. The first 6 months of diagnosis was the worst I'd experienced within the healthcare system because, one, there was no education on what diabetes was. We didn't have any idea what it was. My family, no one has it, so no one knew how to take care of it. And we were not given information on how to go about dealing with the condition. We had 4 different opinions from 4 different doctors, and we got different answers. One, I was told I did not have diabetes at all, so I should go off all the medications. I was told I had diabetes, but I wasn't given the type. I was told I had type 2 and was given orals, but no one really took in the effort to go and find out what exactly was the problem. It took me having to go into a coma for 2 months, having bilateral foot drop and other complications before finding out that I had type 1 diabetes. And after that, it took the assistance of a family physician that I personally am appreciative of, Dr. Elizabeth Banker. She is a family physician that runs the only adolescent clinic in the entire country. And she's the board chair of Diabetes Youth Care. She came to the hospital, came to look for me, and found out about my condition and gave me the ability to be able to get information on the condition and the proper management practices. And I was a very angry person at that point because I didn't believe I had to go through all that to find simple information. She directed me on how to be able to direct that anger into advocacy to help other people in similar situations like me. So the work that we do as Diabetes Youth Care is multi-sectoral. We deal with patients group, caregivers, and the healthcare facilities. So with patients group, we have mentorship programs, we have monthly support meetings, we have online programs where we give daily and weekly awareness issues, not only on diabetes, but then on other non-communicable disease and infectious disease as well. We educate caregivers as well, and we have annual camps that are free for persons living with diabetes. We include non-medical volunteers who do not live with the condition to spread the awareness. We also advocate with schools and do screening exercises in schools across the country as well. And we also deal with insulin distribution and diabetes supplies and medication across the countries. Outside of Diabetes Youth Care, a member of Voices for Pen Plus, I said this initially, it's been a very pragmatic solution on what integrated care on NCDs should look like, especially at the district levels where access is very difficult for individuals in remote areas. And Pen Plus is able to deal with that, where we see pragmatic impact of reduced morbidity and mortality, and also the strengthening of healthcare systems through training of local and primary healthcare professionals. I also deal with mental health advocacy with abysmal production through creatives, theater arts, music and poetry. And we do that through young creatives, and we usually do it in school settings and with the working class as well. And also for Rotary International, where our area of focus is disease prevention and treatment. Thank you.
Fantastic, thank you. And I think what you're just sharing there really highlights just, the sheer challenge of even getting a diagnosis for some of these NCDs, and then obviously the power of just one healthcare physician at the primary healthcare level that can do so much and change someone's journey and life, really. Joe, let me bring you in. I mean, we've heard from these different sectors. You're the Director of Social Responsibility at Novo Nordisk. Novo Nordisk, obviously a pharmaceutical company that's obviously active in access to care for diabetes, obesity, and NCDs, but people perhaps less know, sorry, can't get my words out, know less about the work that you're doing on the prevention side of things. So curious to know kind of what motivates the company to be active in child health and well-being, and particularly on prevention.
Thanks a lot, Katie, and thanks to the other panelists and Maura for the nice plenary session. It's a great honor to be here today and talking about a really important topic at a really important time, as you mentioned, Katie. Novo Nordisk has a history of more than 100 years, and I think one factor is actually our ownership structure. So few people may know, but in Scandinavia, it can be quite common to have an enterprise foundation structure where you are actually owned by a foundation, and in a way that enables you to have a longer-term perspective and to embed sustainability into the business model from the get-go. And that is played out in our approach to looking at things from a sustainability perspective, which we call our triple bottom line, which is, of course, we need to be financially sustainable. We need to think about our environmental sustainability, but we also, as a company active in the healthcare and health space, we need to think about our social sustainability and social responsibility. And I think that stems both from our viewpoint as, the responsibility of the private sector, but it also stems from the pragmatic perspective also that sustainable societies and healthcare systems are, in the long run, good for our business. We need to work in a system where the majority of preventable NCDs are prevented so that those people who do unfortunately go on to develop NCDs that require treatment are able to get that in a strong and well-functioning health system. So I think that's why, as a company, we have a long heritage in this space and why we look at our social responsibility from that perspective. And then, of course, I think the question has already been answered, why children? Because I think, everyone in this room probably by now knows around the effectiveness of early prevention and management of NCDs, and the fact that a holistic approach is necessary to bend the curve. So as you mentioned, we contribute with healthcare innovation, and that's something that we are dedicated to as an innovative pharma company. But we also believe that change will only happen at scale through policy change that requires tireless, endless advocacy, so supporting organizations, civil society organizations, but also intergovernmental organizations that can make that change happen at the population level, then also scaling effective prevention programs at the local level and thinking about health system strengthening. And of course, that good work requires resources, which we can contribute as the private sector. It also requires global footprint, and we are present in many different countries, so we can also build local partnerships and local coalitions to make change happen. We don't believe the private sector can do it alone. We need to partner with civil society, with international governmental organizations, local authorities, and healthcare professionals. But we do believe that real change can happen, and hopefully later in the discussion I'll have a chance to talk to some of the proof points around this, such as our Cities for Better Health program, but also changing diabetes in children, where we've invested in prevention on the ground and also health system strengthening. So looking forward to continuing the conversation.
Thank you. So we've had one round of kind of getting a sense of the different organisations and the different types and approaches that they take on tackling childhood health and NCDs. And now we're going to shift our focus a little bit to try and tease out some of the practical lessons learned, the insights that we can draw from these examples and hopefully replicate in other countries and globally. So Mauro, let me come back to you. So you were obviously kind of sharing in your presentation and in your first intervention the kind of multi-sectoral approach that UNICEF takes. Curious to know kind of what are some of the lessons that you can draw from designing successful multi-sectoral responses that put children at the heart of obesity and NCDs? What are you seeing as some of those lessons and those insights?
Yeah, sure. I will use again the example of the work that was done at the policy level to really build food environments that promote and protect the diets of children. And before joining the UNICEF headquarter level, I was chief of nutrition in Mexico, and I had the chance also to work within the partnership between UNICEF and Novo Nordisk. And so I was part also of all those improvements that the country has done in getting to establish a comprehensive set of food and nutrition policies. The first thing that I think was very successful was the whole of society approach, because every actor there in that complex process played a very important part. The government was leading and was brave, to fight also pressure and lobbying from powerful actors to implement and to adopt and implement the policies that are needed. Evidence played a very important role, because Mexico was in an epidemiological alert, because the level of obesity and diabetes was so high that it was a real crisis. So the crisis called also for important measures. The civil society was very much organized and was able really to bring to the attention of the public the problem of the diets of children that was really entrenched with unhealthy foods, with a consumption that was excessive in every life stage, and also showing how it was possible, and explaining in clear words how some measures that might appear restrictive were actually not restrictive. For example, one of the arguments was that people were claiming that they need to be free of choosing the food that they prefer, but one of the response was that you are not actually 100% free, because what is available, what is accessible, what is affordable, and even sometimes what is desirable, it is dictated by the environment where you live. And the marketing strategies that through the internet or through even in the schools or in the TV or in the public spaces were consistently promoting unhealthy foods. And the academia, the local academia, played a very leading role to really bring together the evidence of what type of policies. For example, the discussion about the warning label. What is the most adapted warning label to the nutrient profile model that was developed by PAHO for the continent, and how does this apply to Mexico? And then the UN, they come well together. There was a joint initiative between PAHO, FAO and UNICEF to really align in the advocacy messages and to support the government, even in public spaces, to really step up for the rights to food and nutrition. And also, I think the principle-driven engagement with Novo Nordisk that also provided some support. And it was interesting also to see how every agency and every actor worked in their spaces, like UNICEF and the UN work in the public spaces, but there is a private space also that is important to influence. So I think this kind of united vision and principle-driven approach was really one of the key lessons learned to modify and improve policies.
Great, thank you. And yeah, the Mexico example is super inspiring in terms of how that comprehensive package came about. Jeremy, let me come back to you in terms of kind of WHO lessons learned and what will be done differently over this next decade. Just a small question to throw at you. I mean, obviously, this week we're talking a lot about the changing global health architecture. We're obviously very aware of the changes within WHO itself, with obviously significant budget cuts and the restructuring that's just been taking place. So curious to know, kind of, after this high-level meeting, what do you think WHO will be doing differently to be supporting this agenda and more broadly on NCDs?
Sorry. I won't, at 5 o'clock on a long day, I'm not going to bore everybody with WHO reforms.
Fair enough.
Other than to say they're very painful. But, and my own bias of having been involved in some of these changes, I do think that, and it goes a little bit to what you're saying about working effectively horizontally. And no criticism of the past, but historically WHO has tended to work down a series of verticals. And we can't afford to do that anymore with the budget cuts that are in place. And so sometimes when it's forced upon you, you have to ask, what's our core role? And with a reduced budget, given the demands on the organization, how can we deliver the biggest impact? And argued very strongly internally, which is all been accepted, that we would shrink the leadership team. So we've gone from 12 executive members to 6. And that's an important step forward. But the impact of that is that you're having to navigate far fewer interfaces. Because I think international organizations, sometimes the corporate sector, certainly governments, struggle with the number of interfaces you have to navigate. Government really struggles to work horizontally. Now, UNICEF, it's in your DNA, and I absolutely respect that. But most governments, most agencies like the WHO, struggle when you fragment things. A whole-of-government approach is a lovely phrase, but extraordinarily difficult to achieve. Because you're talking about bringing together the health ministry, the finance ministry, the education ministry. You're talking about bringing the transport, urban design, parks and public spaces. You're talking about bringing the sports ministry together. And ultimately, you've got to persuade the economics and finance ministry. So that's extremely difficult. Mexico has done it, I think, extraordinarily well. The other country that I think recently developed that I would also call out is the Kingdom of Saudi Arabia. They now have a health in all government ministries and a health focus throughout, including for childhood issues. So it shows you it's possible. Then you have to celebrate success, because there are a lot of cynics who say it can't be done. And when you do achieve it, and not just achieve it on paper, but you actually see the impact coming through, it is really important that you celebrate those successes, because every country in the world is struggling with this, and to learn from others is critically important. And then finally, just on WHO itself and my role in it, this new cluster or division that we call is about health promotion, disease prevention, and care. And those words, promotion, prevention, and care, are 3 very carefully chosen words. It's not treatment, it's broader than that. It's not just prevention, because if we just try and prevent and treat, we will fail in our health systems. We have to also actively promote health. And that means addressing the issues of commercial and social determinants. It means addressing the issues of the drivers of health and ill health, nutrition, food safety, and of course immunizations, climate, urbanization, migration, and other things. So I am optimistic, despite the trauma that the organization's been in, that we will emerge from this with fewer interfaces to navigate and a more integrated approach. If we get 50%, if we get 30% of the way there, I think we will be a better organization.
Great. And I think also the choice of word of care rather than control is very, very welcome.
It did start out at control, and I have to say, in any era, maybe in the 19th century, control would be a reasonable word. I don't think it's a reasonable word in the 21st century. No. You don't control populations or public health. Yeah. It's not a word that I would associate with.
Yeah. And I think also your kind of remarks about the challenges of whole of government and bringing all these different sectors together. I mean, I think it's even more challenging sometimes when the Ministry of Health is not always the strongest amongst the different ministries within a government. So, really trying to ensure that kind of, whole of government response on an issue when that ministry that's meant to be leading is dwarfed by some of the others is a particular challenge.
It is. I'd also go back to what the important role, I think, of cities and or regional governments. Because I'm not saying it's easy in Madrid. I'm sure it's been difficult. But you're on a slightly different scale. You probably have closer ties. I think cities and subnational, WHO, we talk, of course, of federal governments and ministries of health at a government level. I just want to re-stress the importance of regional and city playing the role in this. And I think, for instance, on climate, I think many cities, Paris, Madrid indeed, and others have played an absolutely pivotal role. And I think cities could play an even bigger role in this agenda.
Yeah. Great, thank you. Javier, let's come back to you then in terms of, you were sharing with us that really impressive kind of citywide strategy in Madrid. What are kind of some of the insights and the practical lessons that you've learned over the years that you could potentially be demonstrating and sharing with other cities as good practice?
Cities are uniquely placed to drive action because they concentrate the system that shape everyday life. Education, housing, transport, community services. This gives cities the opportunity to introduce health in all these areas. I think Madrid is a good example of how local governance can lead this integration, and through Madrid Salud and the citywide health center network we coordinate. It's staffed by doctors, nurses, psychologists, social workers, education. They work closely to the community. Our approach is grounded on territorial health mapping and active collaboration with local stakeholders. We have a population strategy and a high-risk strategy, and we prioritize vulnerable population and tailor interventions to specific needs of each area. This allows us generate and act on detailed data such as Madrid has a higher Gini index and risk of poverty than Spanish and European Union average. Or food insecurity affects nearly 10% of households, and it's strongly linked to poor mental health. Or in 2024, 93% of children attended by Madrid Salud were in situation of social vulnerability. And another important aspect that makes cities unique to drive action are supportive models. For us, supportive models of collaboration have been key to advancing our work. The example of CAPI helps local teams to implement and evaluate interventions about physical activity or nutrition. Madrid Salud is proud to be participating in this project, and this project has received a favorable report to the correspondingly ethics committee, which belongs to the Ministry of Health. In 2025, this enabled us to reach 20 schools and encourage more than 4,000 children. Thank you for copy. Another example, we are so honored to be featured in the recent European Commission report, Culture and Health, Time to Act, which highlights our partnership with the Complutense University of Madrid as a model of cross-sectoral collaboration. And another important key is how integrate mental health into urban services. Madrid Salud ran programs based on WHO's life skills framework, working in schools to promote mental health from early ages. So, what can other cities learn from Madrid? I believe there are 4 key elements. A dedicated public health infrastructure with autonomy and cross-sectoral reach, data-driven planning based on territorial health studies, community engagement and co-design of intervention, and integration of health into education, culture, and social services. I think cities that adopt this model can create a healthier environment where children thrive not just physically, but also emotionally, socially, or developmentally. And as the WHO expert meeting on NCDs said in 2022, young people are essential to success. They bring energy, creativity, and network that help us to manage these intersectional spaces. We hope Madrid's strategy can be a practical, affordable, and evidence-based model to fast-track progress on prevention of NCDs and health promotion in the coming years through coordination and cooperation beyond the health sector.
Great, thank you. Very practical and tangible insights. Emanuela, let me come back to you. In your opening earlier, and actually in the morning as well, I'm losing track of the different sessions, you were highlighting some of the barriers around, I mean, you're obviously highlighting that just now in terms of the challenge of diagnosis, but some of the barriers in terms of access to care from a diabetes perspective, especially from a low resource setting. Where do you see some of the kind of viable local solutions to address some of these barriers, and what role should youth play in shaping better healthcare systems?
Thank you, first of all. I believe systems are shaped by perception. That's the first thing we have to talk about. For instance, when we talk about COVID era, the reason why there was immediate response and fast tracking of medications around the world, and the issue of affordability and the cost reduction of these medications was the perception that we had about the disease and then the impact we were seeing happening. We do realize that NCDs are a growing pandemic, and they've had very disastrous impact on not just the healthcare system, but then on our economic scale as well. But we do not see that being or affecting the perception of the people living within the countries or the people affected by the conditioning of themselves. So it means that we can have all the solutions, but if the individuals that need it the most do not believe it's viable or it's important, it's not going to have the impact that we'd want to have. So I would say we should take the lessons we got from HIV, the HIV campaign, and then the COVID period, and use that to shape the perceptions that people have around NCDs in of themselves. We should try to reorient people into seeing the dangers and the impact of non-communicable diseases and why exactly it is important to choose solutions that are viable. So this is where we talk about the issue of public-private partnerships, and I'm going to give an example with Ghana. So Ghana has this partnership with Zipline, where there is the distribution of medication across the country in areas that are very difficult to access. So it means that these areas are able to easily have access to medications because of that. But the problem we have is on the issue of scalability and the funding of this partnership. What the role the youth can play in of itself, one again, is on education and awareness. And when I mean education and awareness, I don't mean we just come and tell them, oh, when you get diabetes, do this and that. It wouldn't work. I said this earlier, that the youth currently are most justice-driven but disillusioned. But they are also the most open-minded generation, but extremely skeptical. It means there needs to be a way to form a relationship with them to bridge that level of disillusionment that exists. The current system has failed several times, so there needs to be an incentive for them to want to buy into the narratives and want to push for change. So the examples we can give is to leverage on existing frameworks. So we have civil societies already doing that. And again, the example with diabetes youth care, it is youth-led, and it is also led by lived experience individuals. So when we go to schools for advocacy and screening, there's more likelihood and more incentive for them to listen and want to put in preventative measures as well. And you get more feedback and buy-in from the community because they see individuals just as themselves being the drivers of it instead of people so far removed from the situations they're in. The next I will talk about is on the inclusion within the education system in of itself. Again, because NCDs affect the most vulnerable groups, that's children and adolescents currently, it means we have to start from the very beginning. Currently in Ghana, the educational curriculum only has materials on infectious diseases. This already exists. All we need to do is expand the curriculum and include NCDs within the curriculum to ensure that individuals or the kids growing up have a fair idea of what NCDs are, the preventative measures, the right management practices, so that we have issues of non-compliance being dealt with, because individuals living with the conditions refuse to comply with medical assistance because their friends will stigmatize them due to the ignorance that is evident within that particular population. And then also on the issue of sustainability, leveraging again on the socialization groups that exist. Youth are more likely to listen to their peers as opposed to people older than them. So let's take advantage of that, and the whole issue of peer pressure. Why don't we flip it for the positive benefit instead of the negative benefit? Because we talk about example with reproductive health, how peer pressure influences that. Why don't we use that and flip it and use it to educate them and say that, well, so we did this example with my peer group where the person with the best blood pressure readings gets a little bit of clout and is able to boost. It incentivized other people to want to push for better blood pressure reading, better sugar reading levels, so that they can have the leverage to be able to boast about it and not just have only their friends speak about it. So we've been able to flip that, and it has worked. We need to scale it up and include as many youth as possible to push and drive for change.
Fantastic, thank you. I mean, I think you're bringing up a few really interesting points there. Number one, the kind of unique role that civil society and community-led organisations have in terms of that trust within communities, right, which governments don't always have, health systems don't always have. It's really the civil society and community groups that do. But then also the peer-to-peer approach is so valuable. We see that, as you say, whether it's in youth to youth or lived experience to lived experience in terms of that approach. And then your last point around kind of really trying to focus on celebrating success when people kind of achieve, particular achievements in their managing of their own health conditions, and sharing that success amongst peer groups is really, really valuable. Thank you for that. Let me come to Joe to wrap up this part, and then we'll be coming to the audience for Q&A, so start plotting your questions now. So Joe, in terms of, we've heard some of the insights and the challenges from different sectors. How about from a pharmaceutical company perspective? What are some of the challenges that you face as the private sector, engaging in and driving collaborations on NCDs and child health, and how has the company kind of overcome or navigated them?
Yeah, I mean, I think you, well, thanks for the question. And I think it's good to address the matters head on. And I think you mentioned it already, is the perception of, bad pharma, and which is, I think something that we need to continuously work to overcome. And of course, I do want to recognize in the context of NCDs, there are commercial determinants of health that are super relevant, and there are health harming industries. But we do in the pharma sector believe that there is the potential of partnerships, and that, we can bring a positive element to and positive solutions to the prevention and management of NCDs, and it's only through collaborative partnerships that we will be able to make a change. So I think our approach to that is to be very straightforward about the idea of partnership, to think about where it is possible and where it's not possible to collaborate. So to identify those spaces where collaboration is appropriate and makes sense, and we can join forces. And then I think also to keep in mind the outcomes and impact that you're working towards, and be laser focused on that, because if you're able to show that the partnership delivered results for children in this case, I think that stands for itself, and it shows that you're committed to finding the right solutions for that right, that right individual, that right community. And then I think also think broader than the health system, and I think many people have spoken about this. What are the other systems that can be strengthened in order to actually make a real difference at the population level? And a number of ways in which we've been doing this. So for 10 years now, we have taken a focus on cities as a place to drive change. For many of reasons that's been discussed, Javier brings the example, but also Jeremy was mentioning, cities can drive change, and they can also be a sort of proof of concept that can then be scaled and replicated, or maybe ultimately integrated into national policy. And one of the things, when we really do believe in the power of community and place-based change, so one of the things we've invested in recently in the context of our Cities for Better Health partnership is the Childhood Obesity Prevention Initiative, where we advocate absolutely for the national policies and regulation, but we do believe where a child grows up and locally also needs to be influenced locally to a certain extent. So we're funding the Childhood Obesity Prevention Initiative, which aims to actually operate at the city level, but operating at multiple levels within the city. So, you know, the city level, the community level, the school level, the family level, to drive change. And we're evaluating that in terms of behavior and health outcomes, with the hope that we see results and can advocate for that to be scaled and replicated elsewhere. We also invest for many, many years in a program called Changing Diabetes in Children, which is aimed at the holistic approach, again, around children living with diabetes, to make sure that the health system is providing adequate standard of care. And we've reached 64,000 children globally with that approach. And then finally, I guess at the highest level, and I think Mauro has alluded to it, we also partner with organizations like UNICEF, because they do things that we can't do, but we believe in. You know, they're best placed to advocate on behalf of children together with governments. So we invest in that partnership globally, with a focus on Latin America and East Asia Pacific, to drive change. And we've been able to reach 3.2 million children directly with that program since 2019, and influenced 18 policy regulations, which is where change happens. And we couldn't do that without an organization like UNICEF driving that on behalf of children. So that's how we overcome some challenges, by thinking practically and pragmatically around keeping the end goal in sight, and thinking how do we actually get around some valid concerns, but also how do we make it practical.
And can I just ask a quick kind of follow-up? How about kind of collaboration across the industry, the pharma industry? It feels like that has changed over the years, whilst I've been in the NCD space at least. Things like Access Accelerated, where it was a whole kind of, not the whole, but a number of different pharmaceutical companies coming together to try and solve some of the challenges of access to care in low and middle income countries. Obviously, there is competition across different pharmaceutical companies, but how do you see that?
I mean, I think absolutely it's a must for us to do it, right? I think it's, of course, we show up as individual companies, but there is a responsibility on us as behalf of a sector. So I think it's not something I've worked a huge amount directly on up until this point, in terms of access, the pharma sector's responsibility in terms of sort of coming together on access solutions. But I think absolutely we participate in coalitions. We participate, of course, in looking at like what the positive contribution of the pharma sector can be to global processes, etc. And where there's duplication and sort of overlap, why we can have conversations about coming together. So, for example, the Novartis Foundation drives a very interesting program called Cardio for Cities, focused on reducing cardiovascular risk in cities, and we're having active conversations with them around how can we work together, because often our counterparts in the city, at the national government, in partners are the same. So why not try to align, again, for the end results?
Great, thank you. So now we come to our audience, and sorry, I've had my back to this half of the room for the whole time. Apologise for that. So I think we've got about 10 minutes for Q&A. So please put up your hand. Obviously, when asking the question, try and keep it as short and sharp as possible. And if you want to focus your question on a certain person on the panel, please do. And we'll try and take a few, and then we'll come back to the panel. So yeah, this lady in blue.
Thank you. Hi. Thank you for the very interesting discussion. I'm Clémence Ellen. I'm a medical student from Switzerland. I'm here with the International Federation of Medical Students Association, which represents 1.5 million medical students worldwide. As a medical student, I often see how challenging it can be for young people with NCDs and other chronic conditions to transition from pediatric to adult care, especially since it often involves different health professionals, system support networks. So my question is, when it comes to childhood health and managing NCDs, is there a particular focus or effort being made to strengthen that transition and ensure continuity of care?
Fantastic question. Let's take a few and then we'll come back. Over to you, the lady over here in beige.
Hello, thank you very much for your thought. It was a very insightful meeting. My question goes to Javier. I'm also coming from Spain. I work in the healthcare here, and I was wondering, considering how the politics of Madrid currently are taking a direction towards the privatization of the healthcare, how do you see that we can manage the prevention and the management of the non-communicable diseases when the private healthcare sector is doing the opposite reaction?
Okay, great question. Let's take one more. Gentleman over here.
Thank you. Two-part question. One is that regarding I think there were 4 interventions that were mentioned that were undertaken in Madrid. So from since we're talking public money, so was there a value for money evaluation done in terms of which one of those 4 or combination of those 4 had the most impact? I think you mentioned dedicated public health infrastructure and community inclusion. I think there were 2 more, so that's first question. And the second question is that maybe this was mentioned but not emphasized enough. What's the role of schools in all of this? Because a kid goes to school and that's where they spend most of their time in a day. So what's the role of actually schools and curriculum in all of this? Thank you.
Great questions. Thank you. So, question around transition of care from pediatric to adult care. Emanuela, do you want to take that? Because I do remember kind of hearing you earlier kind of talk about some of these challenges of that transition.
So with the problem of transition care, I believe it's not talked about much as it should be, because as she said, there is loss of continuity of care, and that's where we see the highest level of non-compliance and risks of complications happening and all that. In Ghana, currently, as I mentioned earlier, Dr. Elizabeth Banker runs the only adolescent clinic in the country, but then there has been work to try to scale it up to other healthcare facilities within the country. And we, as a civil society organization, what we do is we partner with healthcare providers within the various hospitals in the country. So when we have an individual who has the condition, you have these healthcare professionals in themselves coming up and then aiding these individuals transition from the pediatric care to the adult care level by having continual conversation and proximity with the adult clinic to ensure that there is a level of similarity that occurs so that when it's time for transitioning, it's easier for them. And I can give a classic example with the Ashanti region, the Konfanote Teaching Hospital, where that is actively being done in the healthcare system or like the healthcare facilities in of themselves. So we have seen work going on. The problem is on the issue of scaling and making it a national initiative, because currently we do not have that as a priority on the national level. Yes, so that's what I have to say for transition care.
Thank you. We had a couple of questions for you, Javier. The first one, I think I understood as the kind of the particular politics in Madrid at the moment.
Yes, well, I am a medical doctor. I'm not political. And I come from Madrid Salud, from the Madrid City Council in Spain. The medical care are transferred to autonomous community since more than 10 years ago. Then we just work through prevention and health promotion. I have my opinion, but I think that it's not the stage to explain it. But also we coordinate we have municipal health centers, but we coordinate in the territory with the health centers of the health services. It's difficult to explain because we are called Madrid Salud and the other are Salud Madrid. I think I have answered you.
And there was a second question from the gentleman behind related to, I think it was kind of if there had been some kind of value for money assessment being done around the citywide initiatives.
Well, we have a public infrastructure with our own budget. We just collaborate punctually through agreement, but it's not usually. We have our own budget. And when we coordinate with the schools, in college corners, we have our doctor who works collecting data, treating data. We analyze them. And it's similar than the health study. We work by ourselves.
Do you want to come in, Jeremy?
Yeah, I think the question on utility and cost effect is a really important question. I mean, budgets are constrained. And a lot of the conversations we've had, and in other sessions as well, has been about surrogate markers of things. Now, you know, that we've reached so many children with this or that, but that's not what we care about. What we care about is the NCDs, the drive to obesity, and we've got to find ways to study that and to know that we're getting the data that shows that we're bending the curve. It's nice to be measuring some of the things we're measuring, but that doesn't, they're secondary surrogate markers. We've got to be able to demonstrate that the money we're spending and the interventions we're making, are evidence-based, and the evidence is that they roll back NCDs, they reduce obesity, the endpoints we really care about. And I think we're in danger of a little bit of fluffiness around that. And as financial constraints come in, we need the evidence that actually we're impacting on the things we really need to impact.
Mm. And also within a short-term period, political, short-termism is always the challenge of, let's say, 3 to 5 years of a government administration wanting to be able to show results in that time frame.
Yeah, although I think we've got to do something at trying to educate governments that actually, this is a long term. This is not something you do for 2-3 years and then it's done. A, there's a new cohort of babies that are coming through, and B, this is, if we don't bend the curve on what we're talking about here, then the issue of NCDs dominating healthcare systems around the world today is going to overwhelm them.
Yep.
So this is a really critical matter, I think, and one we cannot delay.
Can I just jump in on that? I mean, I think it's a really good point, and it's something that we also believe very strongly in. And so I think in the Childhood Obesity Prevention Initiative that I mentioned, where we are launching this in 6 cities simultaneously, we're going further than we ever have because we really believe that we need to demonstrate whether it works or not in the real world. So we are actually basically approaching it from sort of a real world trial perspective, where we will be collecting data from control and intervention communities to look at whether the package of interventions that we're doing are actually changing dietary behaviors, having a positive impact on quality of life, because the mental health side of it is also important. And then also we are measuring whether or not there is a change in overweight and obesity in the community, which we're not sure we'll be able to show. We hope to be able to show some of the more proximate indicators of diet and physical activity and well-being. And then, of course, modeling what then, the challenge with children is, of course, many of the consequences of poor diets, physical inactivity, and obesity come later in life. But we also want to model that out to see what are the cost savings, what are the health care savings, etc., as a result of that. So we really believe in it. It's tough as well sometimes to convince local stakeholders to join in. And then I think we need to look also at the policy level. What is the impact of some of the policies that are happening? So I think through our partnership with UNICEF, we are also looking at how to support governments and organizations like UNICEF to evaluate the impact of regulations and policy change at the local level.
Mm. It sort of reminds me as well of something that Sir George Lane used to always say, who was obviously kind of a long-standing champion of NCDs. He used to always say, the way that you kind of change the minds of a government is you have to have messages for the head, the heart, and the pocket. And the pocket is, as you were saying, even more important in this day and age, given the budget constraints and fiscal space challenges that governments have. The second part of the question was about the role of schools, and perhaps I could come back to you, Mauro. I think we have touched upon that, but could you perhaps share a little bit more about how you see the role of schools in childhood NCDs?
Yeah, no, the role of school is really significant. If we look at the trends in obesity, we see that they start to increase abruptly after the 6 years. So when children enter in the school age, children and adolescents. This is because many times they get in contact with an environment where in the canteen or in the school meals, they mainly access unhealthy foods. And also inside the school, there is marketing, there is even initiative that in exchange of painting the walls, we are marketing our products. And even outside the school, what we find is mainly junk food. And plus in the curriculum, very often, we don't find a curricula that explain what is nutrition, how is it connected to mental health and to healthy lifestyles, etc. And also physical activity doesn't find the space that it needs. So by implementing relatively cost-effective policies really to improve food environments, and this has been done in many countries, I think about Brazil now. Brazil is a very interesting country because they adopted the food-based dietary guidelines on the NOVA classification system. So they divide the foods according to the level of processing. And they have recently started to gradually ban ultra-processed foods from schools. And at the same time, they continue to foster initiative with local producers. And I think they are obliged to use 30% of their budget for school meals from local small producers. And so schools become also a very important platform for multi-sectoral collaboration between the health for all the regulation and the health promotion within the education and within also the agriculture. So there is huge potential in school for really cost-effective initiatives.
Great.
So one comment on that, because again, throughout the World Health Summit, there's been this sort of elephant in the room around global health and the disruption of, and one particular government in particular. But give praise where it's due. The focusing of that new administration on non-communicable diseases, ultra-processed food, having to get ahead of the curve in terms of illness and promotion and prevention is to be celebrated and acknowledged. Because the US just simply cannot afford to keep going in the way it is in terms of healthcare, and reshifting that focus, if it can be delivered and implemented in nutrition, ultra-processed food, as Mario was saying, and exercise and non-communicable diseases, would be something to acknowledge and celebrate.
Yeah, being seen as a chronic disease crisis, as long as those words are followed up by putting money where the mouth is kind of situation, then absolutely, yeah. Well, I think we're pretty much at time at this point, so I want to really thank everybody, for all of the panelists for joining me, and please join me in thanking everybody. And Jeremy, I hope you know this part, but you're wrapping up for us. Does that sound familiar? Don't worry. I will do a quick summary. But thank you all. Why doesn't everybody take their seats? And I will do a very short wrap up and reflection. So I think that's been a really, really interesting discussion. We've covered so many different areas of the childhood health and NCDs agenda, and obviously mental health as well, as I was kind of reflecting there at the beginning, a really important new aspect of this agenda that we're all working on. I heard very many different sectors' perspectives on this, the different ways that different organizations and sectors are responding. I think a kind of common thread across all of this was collaboration and partnerships. No one sector can do this alone. Really focusing on community-led responses being absolutely critical, and that youth is a really, really powerful driving force, as Emanuela was really highlighting. The passion and the energy and positivity that they bring is absolutely invaluable. I think obviously we've got our work cut out to make sure that the political declaration and the shifts, the really important policy shifts that I was highlighting at the beginning in terms of really putting a spotlight on children and NCDs, translate into sustainable national action and implementation and sustainable financing for this really, really important issue. So thank you again for joining us. Wish everybody the best for the rest of the World Health Summit. And thank you again to our co-hosts, obviously Novo Nordisk and UNICEF, for your collaboration. Thank you.